But we are going to carry on with some wonderful speakers, some very knowledgeable leaders. And so our next speaker is the 68th president of the American College of OBGYN. Now, it's interesting. Breastfeeding crosses over from obstetrics to pediatrics. So we need a whole line of trained physicians. And of course, the family physician is the epitome because they do carry from OB to pediatrics. But if it weren't for the obstetricians supporting our efforts and encouraging mothers to think about breastfeeding before they deliver, you can't walk in and when the baby's 2 days old and say, what do you think, want to breastfeed? So we have the privilege today of hearing from Dr. Haywood L. Brown, as I said, the 68th president of ACOG, just inaugurated recently. He is also the Bayard Center Professor and Chair Emeritus of OBGYN at Duke University in Durham, North Carolina. He has a bachelor's degree from North Carolina State University. He has a medical degree from Wake Forest University School of Medicine. He did his residency at the University of Tennessee in Knoxville, and then he took a subspecialty fellowship in maternal fetal medicine at Emory. Medical education is a lifetime commitment. It never ends. And he's been 30 years active in the American College of OBGYN. He's been a director of the American Board of OB, and he's done a lot of telehealth and telemedicine. And he's been revamping postpartum care. And the mothers in this audience would probably give you a round of applause. His complete biography is in your book. And let me just take a minute to be sure you all got your spiral-bound book. It has a lot of information in it, much of which we could not stand at the podium and share. But there is a bit about Dr. Brown in the book as well. And so it is my great honor and pleasure to introduce the head of ACOG and obstetrics and everything else.
Thank you. Well, good morning. Well, I'll welcome you to the nation's capital, too. I've been every single week since ACOG, my installation on May 8th, I've been here at least one day. And we came on Thursday right after ACOG convocation to meet with legislators about the ACA. And I would happen to be there with the presidents of pediatrics and psychiatry and medicine and the osteopaths and the family physicians. And our theme was that we represent 560,000 physicians and millions of patients. So hopefully someone heard us. And it's also nice to be reacquainted with Julie, Camry Bug, and we've done a lot on breastfeeding over the years, and I'm going to share some thoughts with you with regard to where we are. So I'm going to turn this way because I need to be able to see, but these are the national trends in breastfeeding rates, and I understand I'm setting the theme for what other people are going to talk about today, so I will show some statistics. But my primary emphasis is, of course, on disparity, and we're going to get involved in that to some degree. So as you can see, ever breastfeeding versus breastfeeding for 3 months versus breastfeeding for a year. And the challenge for us in OBGYN is real. You know, we talk and educate the patient a lot about breastfeeding. We do that ahead of time, And we live in a breastfeeding family. 90% of our, hospital, 90% of our patients go home breastfeeding. And so one of the things that we want to know is how many of them are really breastfeeding at 2 weeks? And so my whole objective behind redefining postpartum care is just about that. Because, if we wait to see everybody in 6 weeks, that 90% is cut down to 20% or lower, and even more so for women of color. So these are the breastfeeding objectives. So as you know, you see these statistics. In 2020, ever breastfeeding to 82%, at 6 months to 60.6%, at 1 year 34%, exclusively for 3 months. And I want to promote that exclusivity, because one of the things that we have to remind patients of all the time, if the baby is crying and you're giving it breast milk, what do I say, Cameron? The baby is not crying because it's hungry. The baby is crying because it's trying to decide whether it's going to like you or not, And it may not, when they get to be teenagers, they kind of like it a little bit less. And then they start loving you again. With my kids are like in their 20s, and so now they love me, because, I have the money. So, but they don't like you when they're teenagers, regardless of how much money you have. But that has nothing to do with anything with regard to the breastfeeding. Increasing breastfeeding for 6 months, 25%. Increasing the portion of employees, work site locations. One of the things I had a discussion with at Duke not too long ago as a result of my residence was the fact there were not enough pumping rooms. And so I found that if we didn't have enough pumping rooms for the residents and for the faculty, think about our patients who were, we had some for them in the special care nursery areas and so forth. And I remember walking into the lounge, actually walking into clinic, and one of my fellows is there in clinic with me that day, and I hear this, I said, what the heck is going on here? And she said, oh, just ignore that, Dr. Brown. I'm listening. I'm just pumping. I said, oh, okay. I said, we don't have a room for that? She said, no, but I need to help. We need to get these patients seen too. But again, that's the objective. We got to make it comfortable for people to be able to do it. Proportion of breastfed newborns who receive formula supplement within 2 years to low values. We don't necessarily want to do everything that they've done in New York and places like that to stop giving it out. But the idea is, when I visit Singapore, I'm a part of the faculty at National University of Singapore. They basically, if the patient wants formula, they have to give a prescription for it, and they have to go down to the pharmacy and buy it. They have to go down to the pharmacy and decide to buy it. And that's the approach they have to take to it. So increasing the proportion of live births that occur in facilities that promote recommended care for lactating mothers and their babies, and that's the key. So, national breastfeeding rates. Low rates of breastfeeding continuation and exclusivity is a problem in the United States. Why? Because the patients are not necessarily getting follow-up. And I applaud my pediatrician and family physician colleagues, because they're the ones who are employing the lactation specialists in the office. We in my office, I don't have a lactation specialist, and the first positions to go in the hospital are the lactation specialists. And so when my patients are having breastfeeding problems, they're calling up, they're talking to my perinatal nurse, and we begin to do certain types of things to try to help them with it. And that's the key. So substantial racial and economic differences continue to contribute to these health disparities. So non-Hispanic whites, breastfeeding rates, ever 76.2%. Non-Hispanic blacks, this is old data, but not that old, 58%. Breastfeeding at 6 months down to 27.5%. Breastfeeding at 12 months, 12.5%. So what Jerome is aware of is I still evaluate the Healthy Start Grant in Indianapolis, and which is geared toward infant mortality. And we've got some good news to report, and we've actually published this in the National Medical Association Journal about breastfeeding continuation even in our adolescents. People who have premature babies, that baby needs their milk. It doesn't even benefit as much from adult milk that's donated than preterm baby. Mother Nature is very smart. the protein content in preterm baby milk is higher than it is in term milk. And so even if someone is donating their their term baby milk to her, it's not the same. So when they're coming back and seeing me, I'm having them pump their breasts, they're feeding that baby, and they get it. They get it. People want to do what the best thing is for their baby. We just got to get the education out there to providers of all the things that we're going to talk about today. The rates of exclusive breastfeeding between 3 and 6 months times are lowest among Black infants and infants of mothers who were young, unmarried, had lower incomes, were less educated, and who were living in rural areas. We just wrote a paper that's going to be coming out in the Midwifery Journal, in fact, where we begin to kind of talk about fathers' perspectives. So really it's a matter of educating the couple about the benefits of breastfeeding. And it's interesting what we found. You know, they all kind of agreed that they knew that there was some benefit for it from mom and baby. But at the same time, you know, well, I don't really know whether she should do it or not. Because, you know, and again, that's the part of the education, of helping them to understand as well. So my theory behind that is, the first thing I tell them, I say, well, you know, breastfeeding is the baby's first insurance policy. It's the health insurance policy is better than Blue Cross Blue Shield. And it's the baby's first life insurance policy, and I'm gonna tell you why. I said, what happens when the kid is sick? Somebody's gotta take off from work. When they call you from the nurse and say, you gotta come pick up your kid. I said, in the first year of life, the number of childhood illnesses that go down, ear infections, respiratory infection, diarrheal illnesses, so forth and so on, they're almost non-existent. I said, so therefore, you may not have to take off a day of work for a sick child this first year. You got to get new wrinkles into these things to get people to understand what the long-term and short-term benefits of breastfeeding are. We're not doing it because it's Gucci or not Gucci. You're doing it because it has tremendous health benefits. And I tell you, when I explain that to the African-American couples, it kicks into gear. It kicks into gear. Not to mention the fact, I said, you know, my wife used to tell me, listen, you know, she was breastfeeding. She said, I fed him. I know he's not hungry. You go walk him. You know, do what you got to do. Take him, but get him out of here because I need to get some sleep because I'm going to be back. And he's going to be at it again in a little bit. So I used to ride around the parking lot till they fell asleep. He still doesn't sleep. We got to acknowledge the barriers. Lack of knowledge, embarrassment, widespread exposure to infant formula, inappropriate maternity care practices, lactation difficulties, concern about insufficient milk supply. I tell the patients in the hospital when I'm rounding, you know, the baby's stomach is only the size of a pecan. So what it's getting in the first 48 hours is what Mother Nature wants it to have. That colostrum is real. So don't let anybody tell you the baby's crying because it's hungry. It's crying because what? It's getting to know you. It's getting to know you. And that's the thing. And then when they look at my little finger, come and say, yes, the size of a pecan. So 2 or 3 tablespoons is all it needs. It needs it, though, about every 2 hours. Oh, I get it. I get it. And it takes those kind of physician discussions to make that work. Inadequate physician knowledge and support. That's why we're here today. Because when I educate the residents and educate the students in my clinic, they get it. When they go in and see the patient and they go and stay in there much longer than this, because I only got 3 rooms, I say, you know, she's pretty normal. So if I have to knock on the door, I don't need. They're in there talking about all kinds of things. I said, well, did you talk to her about breastfeeding? Oh, yeah, we'll do that. Forgot about that part. All right. OBGYN specific barriers. I'm an obstetrician. Few families know the health benefits and that they are dose related. Many do not know that small quantities of colostrum are available in the first day is sufficient to meet the needs of the term newborn. What do we have to do? We also have to educate the nurses. Don't bring the baby any formula. Don't get a nipple. Put the baby on the breast. help the patient, they will understand it. And let them know also, it's not easy. I've never done it, but I watch people do it, and it can be hard. And it's painful. It takes a little time to get used to that. Will do better fed or breastfed? Will you bottle feed or breastfeed? I asked them, I don't ask them that at all. I said, so you are going to breastfeed? Sure. Okay. So when they get discharged and they've kind of signed up to the ticket, now I'm going to make sure that someone knows that that's what they want to do. And when I'm rounding on day 2, I'm asking them how it's going. So our practices start right away. We put the baby right on the breast at the time of even of cesarean, because we have the skin to skin where the baby is like finding its way. They know where it is, and they're on their way to it. So these are the data on infant mortality. The second lady was talking about that, and you can look at disparities in infant mortality. And I would say we could clean up a lot of disparities with breastfeeding. That's my story, and I'm sticking to it. We could also clean up a lot of long-term illnesses in adults, including obesity with breastfeeding. It does, Rob. I don't know who I got this from. Probably stole it from Julia. I don't know. But anyway, this is what I show in some of these slides. So this is the difference. Breastfeed milk versus human milk. 3% to 5% fat, 0.8 to 9% protein, 6.9 to 7% carbohydrate, lactose. Energy content, 6 to 75 kilograms. Fat content does not vary consistently throughout lactation, but exhibits a large diurnal variation. It's interesting why the baby falls asleep on the breast. It has to do with the foremilk and the hindmilk, which contains certain lipids. And so the lipids are there, and then all of a sudden the baby gets a little satiety and it falls asleep. But you ever shake up one of those cans of stuff that you get from the store? You can try to make it distribute all kinds of ways that you want. And what happens, you give the baby a bottle of that, particularly a growth-restricted baby. That baby sucks that stuff down so quickly and nothing but bubbles. But in breast milk, because of the foremilk and the hindmilk, you can't simulate that. And that's the differences. Race, age, parity, and diet do not greatly affect milk composition, and there's no consistent compositional difference between milk from the two breasts unless one is infected. The other thing we have to talk to our patients about is if they get a little mastitis and what the rules are for that. That's not an indication to stop breastfeeding. And the first thing that someone tells them, oh, you got to stop breastfeeding. Some mother, some grandmother, or someone from the neighborhood, And that's not true. So this is breastfeeding and risks of post-neonatal death in the United States, which is the other thing we talk about with premature babies. Premature babies that are breastfed have lower incidence of necrotizing enterocolitis. They have lower incidence of SIDS. They have lower incidence of, they counteract many of the post-neonatal death issues that are related that they have to overcome. So this is a study that looked at infants who died between 28 days and 1 year from causes other than congenital anomalies. The longer they breastfed, the lower the risk for infant death. Sudden infant death syndrome, look what happened, which is classified as death from injuries, significantly different. So breastfeeding has the potential to save and delay 720 post-neonatal deaths in the United States every year. Not my work from my pediatric colleagues. They have this data. And this is the type of stuff that we're telling our patients who deliver premature babies. You've got to talk to them about why it's important to keep at it. You're not getting enough? You don't think you're getting enough. You are getting a plenty. We save it, we feed that baby in the nursery. The duration of breastfeeding in months and the association with higher IQ in young adults. This is a Denmark study. But look at this. I mean, this is not my data. This is real stuff. It's 4 to 6 months. Look at the differences in IQs. That's the other thing that I tell patients. You breastfeed the baby, it's going to get into Duke. Yeah. Look at his APGAR scores don't even matter anymore. Start breastfeeding, it's going to Duke. $55,000 a year, save your money. But the reality is there is a data difference in IQ. And then developmental delay. Supplemental feeding, the Millennium Cohort Study. This study sample included all term infants that weighed over 2,500 grams in the survey. 47% initially were exclusively breastfed, but only 3.5% were still being breastfed exclusively after 4 months. 34% were not breastfed. 9% had gross motor delays at 9 months. 6 had fine motor delays. Now, this is our interesting data from Indianapolis, part of our Healthy Start study. And what we looked at was what happens in Healthy Start, which is the poorest of the poor population now, who are involved in the Healthy Start grant program, which is geared toward infant mortality reduction. And what you can see from the time we started, you can look at 44%, 49%, 57%, 53%. But this is basically looking at breastfeeding at discussion during the prenatal visit and actually breastfeeding at 6 months. So breastfeeding initially from the hospital, you can see. But look at what happened breastfeeding rates at 6 months of the poorest of the population. It was at 13 to 14%. That's a big deal. These are people who are going back to work. These are people who are going back to school. These are adolescents, et cetera. But the data I'm most proud of is we will look at it in age groups. Look at the rate of likely to initiate breastfeeding and continuation of breastfeeding in this adolescent population. That's a big deal. That's about education again, telling patients what the benefits are and having them strive to meet them. Now, this looks at weight gain, because one of my challenges, of course, is obesity and obesity challenges, so I'm going to gear a lot of talk to this. But the idea of looking at formula or mixed feeding versus breastfeeding and looking at birth weight and then weight gain. And you can see there, and I don't think my pointer is working, but you get the idea. Weight gain at 4 months, weight gain at 0 to 4 months, energy intake at 4 months, and you can see the difference between the breastfed boys and girls versus the formula-fed boys and girls. And again, the issue is childhood obesity. We can decrease the rate of childhood obesity with breastfeeding. Now, I got this from one of my pediatric colleagues, Joe Jackson at Duke, and he works with me. We kind of have we do the Kellogg Foundation, what do we call it, dog and pony show when we do breastfeeding education, and he is great. And so I would tell you a story about Joe. So Joe, wonderful general pediatric, all my patients end up going to him for a lot of different reasons. But he had 2 boys when I met him, and then they got pregnant with spontaneous triplets. I took care of them. I said, now, that's punishment for a pediatrician, right? She went to 36 weeks with the triplets. And she came in and she said, you need to get these babies out of me today. I said, well, can we do it tomorrow? She said, well, I'll give you until tomorrow, but it's time. Sure enough, we scheduled her. And she worked very hard at breastfeeding all 3 off and on and so forth and so on with different things, and she did it. So then they had 5 boys. So then she basically decided it was cheaper to probably stay home and take care of 5 kids than to get somebody to do it. And then she decided to do school-based home teaching, because that was part of it. She said, well, good Lord, I may as well just stay home and do this. And then last year, they got adventurous. And Joe says, she wants to have another baby because she really wants a girl. I said, odds are pretty bad. Pretty bad. Kate. But sure enough, they just had a girl that's about a year old now. And they are so happy, but they got 6 kids. It took them, the triplets were like a bonus. Who could ask for 3? But they are amazing. But anyway, he gave me this slide because are you mom enough? Or are we supportive enough? Well, we have to be supportive. And so, needless to say, when the baby can start to unbutton the blouse, that maybe it's time. But the reality is that we certainly would like for patients to appreciate the benefits for as long as they can. So let's turn the tables and talk about long-term health. And I want to talk about it from the perspective of the mother because I do this as well. Between 50 and 65% women gain in excess of recommended weight during their pregnancy. And when you look at breastfeeding, it decreases the prevalence of obesity in childhood at age 5 and 6 years in Germany. It overcomes the environment. It overcomes the rise past McDonald's and the Pavlov theories and, the unhealthy cereals and things like that. So months of breastfeeding, 0 versus 6 to 12 months of breastfeeding, statistically significant with regard to obesity, childhood obesity. Now, this is the long-term impact of less obesity. Obesity rates are decreased significantly in breastfed infants. There's a 30% reduction of obesity rates if any breastfeeding occurs in infancy. Any. So I tell the patient who gets a little anxious after a month, I say, you know what? If you can't continue, but the baby's already got such significant benefit, just in a month, if they start to supplement. Well, I have to stop because I have to go back to work. No, you really don't. But if you want to, I can understand that. Duration of breastfeeding is inversely related to the risk of being overweight. Each month of breastfeeding correlates with a 4% reduction in the risk of obesity. 4%. That's a big deal. We got to understand health disparities. It underscores the importance between breastfeeding and weight maintenance. And so those are the discussions we also have with our patients, all of our patients. These are the discussions that at your workshop, Karita, we talk about all the time. It's what it's all about. So if you look at disparities in obesity rates, if you look at non-Hispanic Blacks, race and ethnicity, and how the rates have gone up, and you look at the prevalence of obesity at girls at age 12 to 19, and you look at non-Hispanic Black, it's already there. And so we have to begin to talk to them, especially about decreasing this in children and how breastfeeding can help with that. Breastfed infants self-regulate. They program and self-regulate. And as a result, they have less adult weight gain. They've learned how to program their bodies. So I tell patients, if your baby's growth restricted and it's under 5 pounds, you can counteract many of the things that are going to happen to it in its life because that baby is hungry when it gets out. And if you give it breast milk as opposed to formula milk, it really does improve its long-term health. That's what I mean by the baby's first insurance policies. 75% of obese women gain more than the amount of weight recommended. The more they gain, the harder it is to lose. On average, women retain about 40% of their pregnancy weight gain at 6 months. So they also want to know if the data is true that if they're breastfeeding, they're going to lose their weight different. Well, not necessarily, but we'll talk about that. The studies are mixed. But this is an interesting paper right here because it looks at overweight and obese women are more likely to discontinue breastfeeding before 6 months than normal weight women. Now, there are a lot of theories behind that. And so, women, for instance, who are overweight and for instance, we learn in Healthy Start, you don't want to sleep with your baby. And so someone's already told them that if their breasts are too big, that they could smother their baby. Well, that's the kind of things we have to overcome in the community as well with regard to that. And it's harder. And so you have to also talk about breasts and breast type and nipple inversion. And you all wonder, why does he know all this kind of stuff? Well, I kind of know it because of 30 years of dealing with it. And so I had and again, we got to talk about different types of things. I got a call from one of my same-sex couples. And she came in, and I'd been taking care of during the pregnancy. She was like so upset. This is 2 weeks, because I bring my patients back in 2 weeks. Really struggling with breastfeeding, crying, depressed. And I said, time out here, time out. And then she said something that was very bizarre to me. And I don't know whether there are any religious people in the room or not. She said, well, my mother told me I was being punished by God. I said, well, you know what? God gave you a good doctor. I said, so let's fix this problem. I said, just go around this way. And sure enough, we worked with her with the lactation specialist. It turns out that she was just having some problems and she'd got herself so worked up she couldn't deal with it. But the bottom line was that she ended up doing fine. She was pretty heavy, and we basically dealt with that. And we helped her, which allowed her to continue. Type 1 diabetes, not type 2 diabetes, type 1 diabetes. Infants exclusively breastfed for at least 3 months, a 30% reduction in type 1 diabetes. You know why? Immune factors. Immune factors that lead to type 1 diabetes. 40% reduction in type 2 diabetes. And this reflects the positive effects of breastfeeding on weight control and self-regulation. This is a big deal. So you got to get outside of your comfort zone when you begin to educate physicians and medical students about the short and long-term health benefits. And this is why when Joe and I give this grand rounds every year, we give it at medicine, we give it at pediatrics, we give it at family medicine, we give it at OBGYN. We go throughout the campus and we give this, he does his part and I do my part. Excessive weight gain during pregnancy and long-term maternal older weight and obesity. We talked about that. This is a study that looked at 2,500 women in a cohort of 7,000 women that were examined for 21 years. Women who gained excessive weight during pregnancy were 2 times more likely to be overweight themselves. And children. So, what do we know? Increased rate of pregnancy complications, increased risk of hyperlipidemia and diabetes and hypertension and cardiovascular disease and mortality, increased risk of cancer. Implications of lack of weight loss postpartum is a big deal. And so part of our goal also is working with patients to help them achieve a healthier weight. And when you work with them, you're also working with their children. You're working with their children. And so when the patient comes back to see me, I say, well, where's the baby? Oh, left it with somebody. Also I'm actually interested in, trying to figure out how the baby is doing with the breastfeeding, so forth and so on. But, the bottom line is that we get that information out there, and that's what education of the docs is all about. Now, one of my things for ACOG is pregnancy and long-term health. Heart disease is the number 1 killer of women. Not cervical cancer, but heart disease. And so when you're educating OBGYNs, you really have to discuss that too. So you looked at a cross-sectional study of 297 women in this age group, tomography, coronary, and aortic calcifications. Mothers who had been breastfed remained more likely to have aortic calcification than mothers who had been consistently breastfed. And this is data that your carotid plaque starts to build up, as you know, when you're an adolescent. If you've been breastfed, the odds are less that you're going to have cardiovascular disease. Now, I gave a talk at the Mother's Day March 2 weeks ago, and we were talking about what maternal mortality was in the early 1900s. Not maternal mortality, but women only lived until they were about 49 in 1900 until 1920 or so. And again, part of that was parity that increased the risk of heart disease, among other things. But the bottom line is that this is old data from a European study that suggests that if they have been breastfed, their risk is lower from dying of cardiovascular disease. This is another study from Bayard. 732 participants, 1,300 families, 16 centers in England and Scotland. They surveyed the diet and health in children aged up to 20 years from 1930, born between 1937 and 1939. Duration of breastfeeding was obtained from direct questions of the mother. And look at the femoral and carotid plaques were measured on ultrasound. Again, decreased in patients who had been breastfed. And so when you look at this data, it's very real. So the relationship to being breastfed and cardiovascular disease are real. Now, I was breastfed. I was number 5. I'll give my disclaimer. But I do have some stress-related issues. Being an academic person for 35 years would get you a lot of hypertension and a lot of anxiety. So I think that the only reason I'm got those type of things is a little genetics and a little stress. But the reality is I have a normal cholesterol. and I have normal fractions, and I do exercise. And so I think that has a lot to do with my mother. May just have to do with the fact that my mother lived until she was 98. I don't know. But I'm claiming the fact that she breastfed me. Look at breastfeeding and adult blood pressure. Duration. Never, it's up here. 4 to 6 months, it's down here. This is real data. This is what we can tell our patients that they're giving. You understand what I'm telling the patients, that you're giving the baby its first insurance policy? This is life insurance, not to mention health insurance. And when I have to explain, when I talk to them about things like this, they get it. Not breastfed, breastfeeding for less than 4 months, breastfeeding for 4 to 8 months. Look at the numbers. Big difference. Big difference. And that's our goals. That's what we're talking about. We're talking about long-term health. We're talking about long-term health. Type 1 diabetes and breastfeeding, I've shared with you the case control study. It's real. If you look at type 1 diabetes, again, along this map, look at what happens to it when patients have breastfed for more than 12 months, have been breastfed, versus controls. You can see what's happening over the course of time. That's real data. Not my data, but adult data in people who have that kind of studies. Again, European studies, because they have much better databases than we do. And then type 1 diabetes odds and so forth. This is a study from here, National Health Survey of 1 and 2, looking at huge amounts of data and looking at 15 years, there's a decrease in the risk of diabetes by 15%. Big deal. Risk of sustained controlled current body mass index. So again, when we're talking about disparities, I'm ventured to say that 6 months of breastfeeding in an African-American woman can change the whole disparity paradigm for her children. It can. So we got to get the message out, and we got to be willing to say it. Now, I will also share with you, I just wrote an editorial for a paper that I reviewed. And it's a sad testament, because what we looked at is a discussion on the Institute of Medicine guidelines for weight gain and breastfeeding and so forth and so on. And what we found is that 20% of the surveyed OBGYNs were not familiar with the Institute of Medicine guidelines for weight gain. Now, I would say that as part of it was cynicism as well, because one of the things we realized is they don't really talk about it because they don't think the patient's going to do anything about it. They don't talk about breastfeeding because they make judgments. You don't make judgments. You don't make assumptions. You talk to your patients about the benefits. That's what you do. If you start going in judging, well, she's on Medicaid, so she's not going to do it anyway. And that's exactly what the data showed. They were much more likely to talk about to the private patient about it than they were the Medicaid patient. And they also were more likely to talk about weight gain in a patient who was already walking in looking like a model. Because, they're comfortable with that. But we got to get people out of their comfort zone and begin to talk about things that are real. So this is type 2 diabetes. This is, again, that survey. So I'm going to close with this. Many perinatal risk factors for long-term adverse health outcomes are not modifiable. We can't change our genetics. History of complications occur, but breastfeeding is a simple, inexpensive behavior that's available to all women that has significant positive short and long-term health effects for her infant and for her. If I say nothing else today, take that bullet point with you. That's really what it's all about. I'm redefining postpartum care for a lot of reasons. Rapid hormonal changes, physical, social, psychological changes, challenges being fatigued, breastfeeding, learning to care for a newborn, navigating pre-existing health conditions. Spent a lot of time in other countries. So I was just in China and Shanghai in November. One of my colleagues there is pregnant. She's getting ready to have a baby. Her husband's also a physician. Her mother's already moved in. Her mother's there to help her figure out how to be a mother. The same thing when I was in Riyadh, Saudi Arabia. She and the baby go to mother's house. Husband comes to visit once a week, teach them how to be a mother. Again, we need more of that. We have kind of gotten away from that. So what I have to do is I have to educate the partners. I said, since you ain't going home with the mother, you don't want the mother there anyway, you've got to deal with this. You know, take your turn. Do the right thing, and they get it. 6 perplexes cohort studies on postpartum depression. Not breastfeeding and early cessation of breastfeeding was associated with postpartum depression. My patient was already depressed, struggling with breastfeeding. I didn't want to make it worse. Depressed mothers are more less likely to initiate breastfeeding. Women who are breastfeeding at 1 month or were worried about breastfeeding were significantly more likely to become depressed than those who did not worry. So we had to get over that because, you know, I said, I don't want you to drive yourself crazy. It may not work for you, but you've already done it for a month. And guess what? Baby's already gotten some benefit. So if it doesn't work, we're going to be okay, and you're going to be okay. And that's what you have to do. Timing of the prenatal visit. The reason I want it to be at 2 weeks because I want to redefine the infant feeding plan. We want to talk about reproductive life planning. We're talking about pregnancy complications. We're talking about emotional health and doing a depression screen. We're talking about postpartum problems. We're talking about chronic health outcomes. And that's what we do. And that's why we're redefining when these visits occur. I think patients need 2 visits. One between 2 and 4 visits, and one between 4 and 12 weeks. And the reason 4 to 12 weeks, if women have got family and medical leave and they're going back to work, what is the biggest thing they're concerned about? Child care. And when they have to go back to work and where they're taking the baby, and I tell them, I said, you know, you're not going to get called very much because you're pumping your breast and you're sending the milk to the daycare with them and they're feeding the baby your milk. I said, keep doing it. You'll worry a lot less. Just, you know, make sure that your workplace have a place for you to store your milk. And that's the key. Postpartum weight loss, here's the data. It's very inconsistent. I still tell patients that there's a good likelihood, but 3 prospective cohort studies returned to pre-pregnancy weight, total 400 patients followed for 1 to 3 years. 5 prospective cohort studies, postpartum weight change was minimal. So again, it's very inconsistent, but overall, we think that there may be a negligible effect, but the bottom line, we say, you know what? Control your diet, you're gonna be okay. 10 steps and evidence-based measures to improve breastfeeding initiation durations exclusively. Prenatal encouragement from physicians associated with a 3-fold increase in breastfeeding initiation. Not my data, someone else's data. In low-income, young, less educated women. We were able to show that in Healthy Start. A 5-fold increase in Black women and an 11-fold increase in single mothers. That's what physicians can do. If you believe in it, you can sell it. The same thing held true in a family medicine study with smoking cessation years ago, is that when the physicians were trained in smoking cessation and they walked in the room with that plan, that those patients were less likely to smoke. And, you know, if you walk into an attitude that they're not going to do it anyway, then guess what? They can see that in your face. You all go to the doctor, you know when they're sincere or not, don't you? You know? And you know whether they're really in it for you. And I said, you know, I tell my doctor when I go to him, I said, you know, I'm the walking well per se, but you don't know that unless you sit down and talk to me. I may have other issues. Oh, doc, come on. He's been seeing me now for about 15 years, so he knows me. I said, you know, I paid my copay. I want my time. And that's what we do. Collaboration with Pediatric Communities to help develop optimal breastfeeding support programs. Coordinate with community-based healthcare professionals and certified breastfeeding counselors to provide comprehensive breastfeeding support. Promote hospital policies that support the steps to successful breastfeeding. That's what we can do as docs. Talk to everyone about breastfeeding benefits. Make no assumptions. Understand the critical time windows. Consider targeting groups who are substantially less likely to breastfeed, and support local breastfeeding initiatives. Disparity in birth outcome. Prematurity, low birth weight, growth restriction, pregnancy complications are factors in the ethnic disparities of development of adult conditions such as these. Breastfeeding is an insurance policy. It's a life insurance policy, and it's a health insurance policy. And that's basically my story. And I hope I have time. If I may be out of time. All right. Questions? Go to the mic, please. Yes. Go to the mic. And people accuse me of turning the residents and the students to my little clones when it comes to certain types of things. And I accept it and say, yeah, they are my little clones when it comes to certain types of things. You know, I don't want them to pick up all my bad habits, but I do want them to pick up some of my good habits, and that's one of them. Yes, ma'am.
I'm Isla Boyce from UCSD in San Diego. Thank you. This is very exciting to hear you talk about redefining the postnatal visit. And it's not so much of a question, but just to validate what you're saying. We do see the moms back generally within 48 hours and then a week or two later, and if not many more times. And most of those times we're dealing with maternal problems almost as much as baby problems. And I call my OB colleagues if I need to, but they're very busy. And I think redirecting that effort is right on. And I was glad to see your slide on collaborating with the pediatrician too.
Without a doubt.
Because I think that's really important. And I say go for it.
Well, and I think that's so important too. You know, if we talk about these things ahead of time, you know, a lot of my patients are asking me for a pediatric recommendation. And you know, I have, you know, I'm more likely to refer them to one of the practices who has a lactation specialist, and I know that. Now, again, we live in an area where we have patients coming from different areas. But the bottom line is that you just really got to know and believe and work with your partners. And we actually employ one of our nurse practitioners is also lactation trained. And so she deals with a lot of these phone calls. And I encourage practices to do that too. Have one of your nurses, you know, go round. We do that.
No,
you know.
Absolutely. You need to have someone who can help you with those. I mean, it's very time intensive to deal with those problems. So have someone in your office as well. But I like the idea of having that visit at 2 weeks.
Exactly.
That's perfect.
Thank you.
Great presentation, Dr. Carter. Nancy Hurst from Texas Children's Hospital and Pavilion for Women in Houston. What do you say to physicians, OBs, for that prenatal education on breastfeeding that say we just don't have time? We struggled with that and still struggle with it, even though we have our baby-friendly designation, but it's very frustrating.
Well, you know, we always talk about time, and, you know, I'm so, you know, I tell people, I say, well, what are you doing other than talking to the patient? I said, you know, the baby, prenatal care. We're redefining prenatal care as well. What do you do at the visit? Well, first of all, at initial visits now, we don't even need to do a pelvic exam because, you know, we're not doing pap smears if they have normal pap smears and so forth and so on. So what are you doing other than counseling your patient? You're sitting down and you're talking to them about various type of things of normal care and prenatal care. And in the postpartum visit, this is the other thing I say, you know, patients had a C-section. You just looked at her uterus, her tubes, and her ovaries. All you're going to do is look at a scar and talk about how she's doing. I said, that's the bottom line. And so there is time to do it if you abbreviate your message and they know that you care. When you say, so you're planning to breastfeed, as opposed to, are you going to breast and bottle feed? It's a positive interaction. They know that you're invested in them breastfeeding. When you ask the question, so you're planning to breastfeed? Checkbox. That's it.
My physician 40 years ago said the same thing to me. So you're going to breastfeed, right? I don't need to give you the pep talk. So it's just so nice to hear you say that. And that's really all they need to do.
And that's really all you need to do. Yeah. And they know that you're invested when you look at them that way, rather than a box on the chart that says breast or bottle feeding. And you say breast or bottle feeding. You don't look up. You don't even look up. Makes a big difference. I had a patient tell me, the residents tell me my patients are high maintenance. I don't think they are. They're just, very inquisitive. And so I was out of town like today, and one of the fellows was seeing my patient and one of the professors. And she got very upset with me and sent me a text immediately because certain patients do get my, especially if they're physicians on campus, they know how to email me and find me. And she said, I'm just so upset because I saw your fellow today, and she didn't even look up at me. All she did was type on her chart. I said, okay. But was everything okay? Well, yeah, everything's was fine, but how did she know everything was fine? Because she didn't give me that. So I sent Emily a little note back. I said, TLC. She said, well, nothing was wrong with her. I said, well, she felt like you just were not paying attention because you never looked at her. All you did was type. So that's what I mean by asking the question in a very positive manner. Yes, ma'am.
I'm Justana Cooper. I'm an OBGYN in private practice outside of Birmingham, Alabama.
Wonderful.
I was wondering from an ACOG standpoint and ABOG and residency training guidelines, I can speak that I had absolutely no training in breastfeeding.
I know.
Right? So I had to go and through ABM is really where I learned what I needed to know. Is there any kind of movement to change those guidelines or even ABOG articles? We get a lot on robotic hysterectomy, nothing on breastfeeding. Yeah. Is that in the works?
Well, I've been on the board and I'm actually on ACOG now, and you're absolutely right. The educational materials, and you have a CREOG objective that says education on breastfeeding. But if no one goes in and teaches that module, or no one is sincere about that module, you don't get it. So I teach it in clinic, every clinic, in addition to that. And I give this talk, and I give the talk with Joe Jackson, again, across departments. We also got to get it down to the medical students. We don't want to just start this education when people become residents and when they come. So you're absolutely right. The modules have to change with the focus on women's health, the entire women's health, and that's one of my themes this year. One of the things you're going to see out of the Postpartum Task Force is a white paper that's going to be promoted. We're going to redefine postpartum care didactically with an emphasis on the things like breastfeeding, and it's going to be plumb part of the curriculum.
That's wonderful. Thank you.
So that's the goal. Good morning, ma'am.
Hello. Good morning. I just wanted to say what an amazing voice you are for the community, for beginners, for the intermediate, for experts, and what an affirmation it was to see Jasana, because I was going to say one of the things that I heard from an OBGYN was that they consider there's a passage and a passenger, and that's all. So, breastfeeding is not what we do. And so it's really enlightening, and especially when you're working with postpartum. But thank you for being the voice you are to those 300 folks you talked to last year at the Rose Summit, who were community folks who listen to every word you had to say and how you're working with physicians and medical students, because I, too, have worked with medical students who weren't very interested in what I had to say until 3 or 4 years later in private practice, and all their mothers were breastfeeding. And then they wanted to call me back and say, can you tell me that again, and send me those handouts. So thank you so much. Right. And I'm going to continue to call on you everywhere, and because you are just amazing, even though you told me don't call you anymore this year because we've been wearing you out, a little bit of it to Julie. See why, right? Thank you.
But stay tuned, because we're going to continue to write some data up too. Writing papers is part of this for me as an academic doc. That's why the Healthy Start data is in here, talking about how we did. And again, every time I have an opportunity to give anything, I put this in a contraceptive talk, because I talk about lactation and amenorrhea. Got to be careful, but I tell people how long they have to be careful. Keep going.
Hi, I'm Jennifer Canvasser, director and founder of the Necrotized and Intercolitis Society. And my question is for the mothers who cannot directly breastfeed, how do you prepare those mothers for weeks or perhaps months of exclusive pumping and the benefits, obviously? If you could just talk about how you prepare those mothers and those families.
Well, I'm fortunate to have a wonderful, wonderful group of neonatologists that work with us. And so we began to talk to them about that when they're going to deliver a premature baby. Now, we've already talked to them about it during pregnancy, but again, we have to kind of re-emphasize the importance of them not getting discouraged by having to pump and give that baby that milk when it's only like 1,500 grams. And that they're prone to a little bit more issues. And sometimes we'll even prescribe, Reglan for them because there's not very good data on it. But you know what? I tell them, I say, if you think it's going to help, we're going to do that. And so that's the type of things that we do. And when we're seeing them back for that 2-week visit, they're sometimes still visiting the baby in the hospital. And we also are fortunate enough to be right close to them, and we can kind of encourage them to do that. And I tell them also, you're in the hospital with the baby, walk over to the unit and ask to speak to the lactation consultant. Walk over to the unit and speak to one of the residents. And if they don't respond to you, call me. We go from there. All right. I know it. She's the last one.
My name is Alana. I'm from one of the WIC agencies in Los Angeles. And in terms of prenatal education, we do a lot of prenatal breastfeeding education. But what a lot of people don't know is our resources are all available for free for you to use in your offices and in your practices. The California state website has a lot of great breastfeeding education materials. The state is currently under reconstruction on their website, so it's a little bit tricky right now, but very soon, hopefully, they'll be back up. But at our agency, we have online education, which is open to the public. So you don't have to be a WIC participant in order to benefit from all those classes.
Well, that's
So
great.
it's a good resource.
I think all WIC centers are doing that now, and it's very helpful. Thank you very much.
Well, thank you.
Thank you. All right.